Okay, good morning everybody, and thanks for getting up early and joining us for this, this breakfast symposium on deep learning solutions for effective cardiac MR. My name is Eigil Samset, and I lead the global cardiology care area team in GE Healthcare. And I'm thrilled to be here at the Cardiac MR conference. Probably been more than 20 years since I went to MR conferences. I did my PhD in MR more than 20 years ago. But now really looking quite a bit across different modalities. And the team that I'm leading is a team that is looking to help healthcare providers, both in the cardiology department as well as in the radiology departments, to really focus on patient outcomes. To really focus on how can we optimize care pathways and optimize clinical, operational, and financial outcomes for patients. But obviously, each of the technologies that are being used in that pathway are critical in terms of how we do that. And before we sort of dive into the topics today, I just wanted to take one step back with you guys and think about cardiology and sort of what's happening in terms of dynamics in the market and what we see in the field today. And I think one very interesting area is the focus on really rapid diagnostics, looking at how we can help reduce the time from, let's say, symptoms to action. And just to take one example there with the new guidelines related to chest pain, today and maybe in the past, we've been doing so much interventional coronary angio, and oftentimes those end up being negative and no need for stenting intervention, for example. But with the new guidelines and focus on non-invasive imaging, both with CTCA, but also with stress imaging with MR, we see that sort of dynamic is shifting quite significantly. So some of the market outlooks look at really a reduction in diagnostic catheterization and a quite significant increase in non-invasive imaging and stress imaging with both CMR, CT, and other modalities. And then we see the advent of artificial intelligence and the use of AI to not only improve the way images are being acquired and measures that we hear about today, but also look at how we can predict disease progression, risk stratification, and understand which patients might be responding to certain therapies and who may not. And in particular, in the whole area of transcatheter therapy, you're aware of all the innovation happening there. So many devices are currently in trials, and I think when we talk about MR and imaging, is just such a crucial element in terms of the diagnosis, the workup, and sometimes also the intervention itself and to guide it. And then finally, the whole transformation in the way that we are providing a care model today, moving from inpatient to outpatient therapy and also looking at doing much more in the home for patients. So I think with that background, some of the challenge that I'm discussing with a lot of cardiology administrators and chairs of cardiology is how to rethink the cardiovascular service line today. You know, with the drive to value-based care, we in GE believe that we are a great conversation partner with really solutions across the entire pathway that can help to look at different ways to make that change. And also with the physician burnout, the workforce challenges we're seeing in the marketplace today, I think the whole toolbox of technologies, including AI to automate measurements, to automate reports, is going to be a very helpful element there. I mentioned the shift to transcatheter therapies where obviously image guidance, and I'll mention something interesting related to MR and image guidance later today when we talk about therapy. And then finally, the super specialization of multidisciplinary teams. Radiologists, non-invasive cardiologists, invasive cardiologists have to come together and sort of really create the best care plan for each patient. So in GE Healthcare, we're trying to look at innovations and solutions that can help in all these areas, looking at ways to help providers optimize their care pathways, looking at new AI-driven technologies that can really aggregate information about patients, both clinical information as well as imaging and sensor information across the pathway. Look at new ways to deploy virtual health, both in the hospital, in the community, and sort of as a network of actors across the care pathway, and also really to empower heart care teams to have the best possible tools throughout that pathway. So we believe that we are in many ways in this together. Academia, clinicians, industries, I think we all have shared objectives in terms of really creating the best outcomes for the patients. And in some of the ways that with the challenges that I outlined today, it's about really creating system efficiency centered around the patient, utilizing digital health tools, and then with the ultimate objectives of really improving outcomes. And before I give the word over to Martin here, who's going to take us through some of the new innovations from GE in the cardiac MR space, I just wanted to share with you a hot from the press update. I mentioned using MR to not only diagnose, but also to guide therapies. And this is kind of personal to me because almost more than 15 years ago, I did my postdoc at Harvard looking at developing MR-guided EP ablation. But now GE Healthcare is starting to collaborate with Imricor around combining Imricor solutions for doing EP ablation in MR with our imaging equipment. So I think that's going to be a really interesting adventure going forward and look at how MR and cardiac MR can be used not only to diagnose therapy, but also to guide some of those more complex procedures. For example, ventricular tachycardia ablation that can really benefit from using MR to target precisely, as well as using MR to really guide and monitor the therapy there. So there's a press release out that you can look up if you want to read more about that collaboration. But with that sort of brief introduction, I'd like to give the word to Martin, who's going to talk you through some of the new innovations that GE would be introducing in the marketplace. Martin?
Thank you, Eigil, and also a warm welcome from my side. Thank you for joining our symposium today. I'd like to introduce some recent product innovations to you and how these transform cardiac MRI practice. So to recap, many of you use efficient, shortened examinations already. This is an example that follows the SCMR white paper that was published last year, including cine imaging, T1 mapping, T2 mapping, stress-rest perfusion, and late gadolinium enhancement imaging. This was done on a 3 Tesla Premier scanner and completed in 22 minutes. This is done today, and much of this is improved and enhanced with the AIR-RECON-DL technique. AIR-RECON-DL is our deep learning-based reconstruction that increases your productivity by enabling shorter scans. It removes image noise and removes ringing artifacts. It delivers sharper images, and you as a user can select your preferred SNR improvement level. There are peer-reviewed journal articles about AIR-RECON-DL and what it means for clinical practice. One is from Erasmus Medical Center, published in European Radiology in 2020, applying it to late gadolinium enhancement imaging. And this paper shows an increase in image quality with AIR-RECON-DL, as well as increased image sharpness. And then second, the paper from Monzino, published in the International Journal of Cardiology in 2021, comparing the breath hold segmented late gadolinium with single-shot late gadolinium imaging. They showed a 3 times shorter exam time for late GAD, while achieving superior image quality with similar diagnostic accuracy with the single-shot AIR-RECON-DL approach. So really a strong story for moving more towards rapid single-shot imaging enhanced by AIR-RECON-DL. So we're really proud of AIR-RECON-DL and have made it available widely across anatomies and multiple image contrasts. But of course, we haven't stopped there. So today, I'm happy to introduce to you our new deep learning. This is SONIC-DL. SONIC-DL means MRI at the speed of light. SONIC-DL is a deep learning accelerated Fiesta Cine for the rapid assessment of cardiac function, masses, volumes, and structure. We designed it to reduce exam time while preserving image quality. We have free breathing and breath hold options. It's always retrospectively triggered to cover the whole RR interval. We use up to 12-fold image acceleration, and we can go as fast as 1 heartbeat per slice. That's the example you see on the upper left here, the 1-beat scan, dramatically reducing scan time. But also look at the lower left, the 6-beat scan means shortening breath hold times from 9 to 6 seconds in this case, while improving image quality. So it's really a very versatile tool, and I think we're going to use only 4 protocols. One is the high resolution protocol, 6 heartbeat protocol with 1.4 millimeter resolution here, 23 acquired temporal resolution for valvular assessment, for example. Then your standard rapid cine is going to be a 3 heartbeat protocol, most likely the most commonly used protocol, dramatically increasing scan times. Then you have the arrhythmia option. Patient with severe arrhythmia, you want to go with single beat imaging. This is the single beat breath hold here with 12-fold acceleration. And then, last but not least, also the free breathing option. Respiratory triggered, free breathing, highly accelerated, really rapid tool to assess cardiac function. Also here, there are peer-reviewed journal articles, one from Stanford University assessing sonic DL cine in the pediatric population, showing 3-fold shorter scan times for cine imaging and showing equivalent biventricular volumes. And then second, similar evaluation in adult patients, also showing no significant differences in biventricular volumes compared to the breath hold cine imaging. So you can see we really have a whole portfolio of air recon DL and sonic DL enabled applications spanning from black blood imaging, late GAT, phase sensitive free breathing imaging, stress perfusion, cine imaging, coronary imaging, high resolution 3D late GAT, and then all the mapping T1, T2, T2 star mapping. So really whole portfolio, and where we see this going is enabling more rapid and efficient value-based cardiac MRI. And if we still look at the efficient CMR white paper, most of your questions can be addressed by stress perfusion, cine, and late GAT imaging as shown here. And we're, together with you as our collaborators, we are working towards really dramatically reducing this. With our deep learning reconstruction, we can enable 1-beat imaging from beginning to end and everything in free breathing with respiratory gating. So you will hear more about this in the rest of the session. The last speaker, Amit Patel from the University of Virginia, will focus on stress perfusion and free breathing late GAT imaging. And the next speaker, Frantix Chen from Stanford University, will focus on the middle column, what it means to use sonic DL for cine imaging. So with that, I thank you for your attention. And without further ado, I will hand it over to Frantix Chen from Stanford University.
Thank you so much. My name is Frantix Chen. I have about 30 years experience at Stanford, but working both in the pediatric side and adult side, so it is in that capacity I come to speak with you. Our topic today is actually just this, put sonic DL to the clinical gamut of testing in a realistic situation, exactly what do we get. Now, I've been long enough around to see about 30 years of development in the cine technology, starting with the segmented case space, allow us to do breath hold kind of imaging, and then balance SSFP 20 years ago to improve the SNR, then come along image parallel imaging in spatial and temporal domain, and now with liquid compressed sense with the highest accelerations possible. The immediate gains of all these technologies is to reduce the scan time for a given spatial and temporal resolution, usually at the cost of artifacts and structured noise. Now, these kinds of artifacts, it turn out, limit the maximum acceleration potentials, even though theoretically you could do better, but when you look at your pictures, when they're highly accelerated, from a clinical point of view, you say, do I really trust this? So that actually is the fundamental limitations. Now, for the deep learning approach to the Cine project really has to ask the questions, if we can recover some of those lost fidelity of the images, can we then push the boundary into acceleration further? And using those kind of accelerations, then you can trade off for other stuff. The preliminary study I've shown by Martin, it could be done down to one single respiratory cycle. I mean, it's a cardiac cycle. If that were to happen, a lot of other issues, such as arrhythmia, actually disappear. So that would be the holy grail. Now, today what we wanted to do is to make sure the foundation is solid in real patient populations. So we examined the sonic DL Cine as applied it in adult populations. My colleague at the Children's Hospital had looked at that on the pediatric side. And specifically, I look at diagnostic quality as seen by practicing radiologists and cardiologists. And then we look at, again, traditional volume, extractions, ejection fraction, but we go a little further. We want to look at the regional mechanics because this is what adult people always look at. What's the regional wall motions, contractions, and all that. That need to be nailed down. All right. So in the methods, the technique of the sonic DL really have two parts. The first part is the Cine sequence that acquire balanced SSFP weighted echoes and then offer sparsely and variably sampled at KT space. Then the reconstruction algorithm is where the magic part is, where the deep learning part in between. This is a non-feedback network system whereby it would try to take the sparsely sampled decay space, magically produce a Cine on the other side. So we recruit our patients that refer to our cardiac MRI on the adult side. The patients that we recruited from are those indicated for ischemic liability study, cardiomyopathy workup, and arrhythmia. So people with syncope or no arrhythmia that come in to look for delay enhancement, we recruit them. This is, of course, done under informed consent and IRB supervisions, and it is done on an outpatient center setting. So we use uniformly a GE Premier 3T system for this task. All these patients undergo their routine protocol, a viability type protocol, whereby we have a long and short axis SSFP sequences, and we always do our traditional protocol that is accelerated by assets, Fiesta type sequence up to a factor of 2, typically 1.5x or 2. After the Cine sequences, we'll add another 10 minutes, where it composes of a longer scan over 6 heartbeat, with breath hold. And then there's a 3, which is intermediate accelerated scan over 3 heartbeats. And then 2 variety of the single RR. These are acquired only on single heartbeats, either breath hold or they are respiratory triggered under free breathing. Now, this is the parameter sheet. You don't really need to look at it all that deeply, but with that said, the resolution is preserved across all tests so that we keep that constant, and then we allow the scan time to free itself. So typically, it's described with the longer RR acquisition. Of course, the acquisition time is going to be longer, but it spans anything from 2-second acquisitions to about 10 seconds. Now, the image quality are collected from 2 experiences, the CVI reader over a 5-point scale of 0.5 increments, and we asked them to focus on the left ventricular performances in adult populations. In the quantitative measurements, we look at the ventricular volume, ejection fractions, but also look at the regional figures such as wall motions, that is displacement of a segment of wall, thickness in diastole, as well as thickening, as in the representation of the contraction. All right, the readers are given a dictionary to see how good or bad things are, so they are well standardized. So a grade 5 will be the pristine pictures on the left side, while grade 2, which is probably the worst that we have seen in the entire lot, will be toward the right side where you have ghosting and other stuff. In terms of quantification, we use the meta suite with QMass version 8.1. We extract RV and LV volume ejection fractions, and we use a 6-segment model over a mid-sections to quantify for wall motions and other wall performance figures. The data analysis is for the image quality. From each reader, we looked at the student t-test as comparing from different acceleration from standard. So it's a pair between the accelerated versus sonic DL versus the traditional asset. For the quantitative measurements, again, the standard is the reference with the assets that we typically acquire, and then we use the blind elements plot to see the differences compared with each of these accelerations. Now, I think this is actually very worthwhile slides because it tells you just what the gametes a patient would put sonic DL to exercise. So even though the sample point is 39, we got 24 male and 15 female. The age group literally is right after pediatric and 19 all the way up to 85-year-old. The weight group from someone who's underweight 45 to morbidly obese 180 kilogram, all right? Now the heart rates also, we got 40 all the way up to 99. So you test the entire range, that's whatever come to you. The ejection fractions have come from 20%, which is severely depressed, and up to 65%, which is normal. So with all that said, all the patients we recruit, majority of them come from workup cardiomyopathy. It could be anything from sarcoidosis, amyloidosis, whatnot. Then the next most common groups are arrhythmia. People who come in with no arrhythmia or clinical symptom that suggest arrhythmia. And the third most common are various kinds of myocarditis, including COVID, COVID vaccine and whatnot. Okay, the first thing to look at is the performance in scan times. The traditional Fiesta scan had a median time about 6-minute acquisition. It's probably fairly typical representation of someone who's doing 1 or 2 slides per breath hold over a maybe 10 or 15 slides or so, and you have to allow patient to recover between breathing. So it's a fairly slow pace acquisitions. The range is actually quite big, even though on the medians is 6 minutes, it can span up to 15, depending on how the patients can recover for you. So as you go down to the smaller, higher accelerations scan with 3RR, for example, the strategy we use is not to breath hold over 3 seconds, but rather you stack up a couple more scans. So in 3RR, typically we do 4 slides before we let the patient breathe again. So by doing so, you need less number of breath hold in order to achieve the entire gamut of scan that we need to do. So for 3RR, we typically can do that under 3 minutes, and 1RR typically about less than 1.5 minutes. All right, so here are some examples on how they look and how the reader grade them. So in the center is the reference. That is the slides that we would typically get for our patients. And the top left is the 6RR. And quite often our reader will identify 6RR actually is better than the standard sequences. In the bottom one, you can see the 1RR acquisition. The one on the right side in particular, if you can see it, you can see the diaphragm moving. And that's the ones that require under free breathing. Now, more typical, this is an average case. The reference, again, is in the center. And you can see that the definitions of the wall begin to deteriorate just a bit as you eye it through, but they're usually still very good. So these are our score with the x-axis plot out the different technique we use, with the leftmost being the references. As you can move toward the right side, it's faster and faster accelerations. The two readers are completely independent, but surprisingly, we track very much what we do compared to each other. We all see a little bump, that is a slight improvement in image actually at 6RR, which is still faster than the asset at 2x. And then the deterioration that we see in the subjective quality at 1RR, which is not surprising. All right, let's look at the quantitative measurements. In the volume quantifications, we use a blind Allen plot. You can see that it's unbiased and pretty tightly clustered. Most of the cases will fall within plus or minus 20 milliliter in diastolic volumes. For ejection fraction, again, it clusters very well. We do have a few outliers. And interesting, in this examination scheme, if something happened in the reference scan, let's say there's an arrhythmia happened there, then you suddenly is going to have a bump. Everybody's going to be off. The reason is because the reference is off. But we'll be honest, we're just going to plot everything as they come. But you can see that most of the cases being clustered about plus or minus 5% in ejection fractions. Each of the wall, we look at all 6 segments, so we end up with about over 200 samples for each of those metrics. So it's a lot of data, all right? Now, I've shown you the blind Allen plot here, a couple superposed between the 3RR and 1R acquisitions, because when we look at these very fine detail, we begin to see that the deterioration in 1RR does come into play when you look at the statistical performance. So here's an example. The blue line here gives you the 3RR performance, which is tighter than see, and the orange line, which represents the 1RR performance. The last one I just showed you was thickness, and then for wall motions, you can see that there's a little widening again, as you would see. The orange one here now is the 3RR, the gray one is the 1RR acquisitions. And finally, wall thickening, what we think about in terms of contractions, again, it's just slightly deteriorations over 1RR. So that's the break point where you go from 3 to 1RR. So in summary, reader report there's no loss of diagnostic quality compared to conventional cine at low RR or moderate 3RR accelerations. There's no significant difference in volume ejection fraction measurement across all accelerations leveled down to 1RR, and that's supported by what the publication says anyway. And the regional figures is an interesting one, such as the wall motion thickness and thickening are best preserved at 6 to 3RR accelerations. The quantifications of the volume ejection fraction at the highest acceleration yields a 4-fold reduction in scan time. That's supported by the actual measure of scan time we did earlier. So we just divide it up. So guess what? It's 4 times faster than, let's say, a 2x asset. And the evaluation of regional wall motion, if we keep it at 3RR, we still get a 2.4-fold reduction in scan time. So something that took 10 minutes before, now you should be confidently do that in 2. That's a lot of gain, actually. All right? There's some kind of references that we have, and that's the end of the talk. Thank you so much.
Hi, good morning. I'm going to kind of shift to the other parts of a kind of a typical stress CMR exam, the ischemia and late gadolinium enhancement. These are my disclosures. So I think there's been a significant change in the guidelines that have happened over the last few years when it comes to the assessment of coronary disease. Essentially, any patient that's at intermediate to high risk, it is reasonable to pick any non-invasive stress testing modality you want that makes sense for that patient, or you could choose coronary CT. They're all really equivalent in it, and you need to think about your local expertise, patient-specific factors, that sort of thing as you decide. Similarly, the ESC guidelines also suggest that as your pretest probability of coronary disease goes up, you should really preferentially be considering ischemic testing over coronary CT. And both guidelines do show that if you're interested in evaluating coronary microvascular disease, then quantification of myocardial blood flow using MRI or PET would be kind of the option for you. So a typical cardiac MRI protocol, a stress MRI protocol, you first get your scout images. You're going to then get T1 and T2 mapping sequences. You'll then do stress perfusion. You may get your cine images after that. Then you get your rest perfusion, your T1 mapping contrast, post-contrast images, so you can do ECV, and then late gadolinium enhancement. And that, if you break out the pre-contrast and the post-contrast part of it, I think in many centers it's about 20 minutes each, and some slower centers that might be 30 minutes each, adding you up to a 40 to 60 minute exam. And this is a problem. It's a bit too long. And for those of us who are at the scanner doing this, we know that our patients get tired by the end, and our late gadolinium enhancement images at the end are one of our most important sets of images. And the data quality starts to deteriorate because you start getting respiratory motion, and then you have to start repeating those images. Additionally, when you have scan time that's in that 40 to 60 minute range, you're effectively reducing access to patients, right? So if you have a shorter scan, you have twice as many slots, and that's more access for our patients. And I think importantly that the 40 to 60 minute scan is financially very difficult to make viable and to convince your hospital that we should really route all of our work in that direction. The second challenge for stress CMR is that the clinical expertise is not widely available. Now, artificial intelligence has a huge opportunity here to help us shorten our scan time, and I'm going to focus on image reconstruction here. However, you can see here there are many other areas from patient selection to improving image acquisition to sorting images when you analyze the data to image quantification where deep learning and artificial intelligence can really make a huge impact. So here we've already learned about the Air Recon DL approach. My understanding of it, and I didn't create it so I don't really know, is that the case-based data is what the deep learning recon is working on and removing noise right from kind of the case-based area. And then this can eventually lead to improved image quality. And how you take advantage of the image quality is really up to you. You could shorten scan times. You could improve your image quality. What you do with that signal is a little bit up to you. Here is our study of air recon DL noise reduction in stress perfusion imaging. And here you have a typical stress exam with the apical slices here at rest and stress, the midventricular slices, and the basal slices. And here we've reconstructed the images from our standard reconstruction to low deep learning level. This is a very touchy screen. Okay, the low air recon DL to medium and high. And you can see how the noise is being removed from the image, and you can easily appreciate how the image quality is improving as you go from standard reconstruction up to high DL, or at least a medium DL. Now here's kind of a zoomed in image to help you appreciate the improved image quality. You can appreciate on the left. No one would argue that there's a perfusion defect on the left-hand side. You can see them both. However, on the right-hand side, especially if you consider a less experienced reader, you can appreciate that all that noise is removed and that defect just stands out much more. And you may have missed that thinned inferolateral wall perfusion defect on the routine reconstruction, but it's clearly even more pronounced on the deep learning noise reduction. Now here, looking at how did this impact the interpreter, and we created a Likert score similar to the one we just saw between 0 and 5, and had 2 readers analyze all these images, and you can see at either 1.5T or 3T, image quality improves as you go from low to medium to high air recon. The other kind of interesting thing is when you look at that medium air recon DL level, you can see that the 1.5T image quality is now behaving similarly to a 3T scanner. So I guess you got a free 3T upgrade. Here, now we also looked at what aspects of the image quality were improving. Of course, SNR was significantly improving. The whole thing is designed to do that. You can see a reduction in the artifacts. There was no worsening of dark rim artifact. It kind of stayed the same, so that's helpful. And then you can see how all of those pieces really led to increased diagnostic confidence. Now, another kind of application of air recon DL is on free breathing PSIR imaging. And so on the top row is our normal phase sensitive, breath held, segmented deep Lake Elliott enhancement imaging with different levels of air recon, and on the bottom is the single shot free breathing images. And you can appreciate that the image quality is improving as you go across. But I think the real key is here, and as I said, for those of us who are performing these studies, a lot of patients, when you do a standard acquisition, will breathe on 1 or 2 or 3 of the images that you have to repeat. And here you can see multiple examples of patients who had respiratory artifact, and then you see the corresponding deep learning, the air recon reconstruction. And I suppose one of the concerns our group had was that there's a big push to quantify the amount of late gadolinium enhancement that you have, and that's heavily dependent on the number of standard deviations your LGE is away from your remote normal territory. And we just got rid of all of our noise, and so is that going to drastically change our quantification? And I think what this graph is trying to show is that, yeah, there is a slight increase in the amount of LG you quantify as you go from one deep recon level to the next. But it's small, but it may be something we need to pay attention to as we start to quantify. You may want to really make sure you're sticking to the same level of air recon and not changing it. Otherwise, you may kind of create some noise from especially doing serial imaging. All right, so I think for me, one of the exciting applications is quantification of myocardial blood flow. So let me just nerd out for 1 second, where what you're going imagine if you really want to quantify blood flow, what you need to do is get a tiny amount of contrast and instantaneously inject it straight into the coronary artery. And then the rate at which that contrast washes out of the coronary artery is your blood flow. So if it washes out quickly, then your blood flow is higher. If it takes a long time to wash out, then your blood flow is slower. Our problem is we're not injecting our contrast straight into the coronary artery. We're hopefully injecting it peripherally into the arm. And so what happens is that as your contrast first starts to arrive into your myocardium, it washes out like it's supposed to, but we can't see that because even more contrast is coming into the myocardium on the very next second. And as that contrast is washing out, we can't see that either because even more is coming in later on. And so our ability to detect this washout is lost because the contrast keeps coming and coming and coming. And so that's kind of one major challenge between how we do it clinically versus how we would do it theoretically, quantifying blood flow. The second is that the blood flow measurement is dependent on the rate of arrival of the contrast agent itself, like what dose did you inject it at, how much did you give, what's the ejection fraction, things along those lines. And lastly, so we need to correct for that rate of arrival of the contrast agent in order to accurately quantify blood flow. However, we can't accurately quantify the contrast coming into the LV cavity because it's very concentrated in the LV cavity. You have all this T2 star effect that reduces your ability to accurately measure what's happening in the LV cavity. So we often rely on semi-quantitative techniques. But I think if we go back to math, and one of my engineering friends tells me math saves lives, and I think maybe he's right. So here, what we're going to use is a mathematical property called deconvolution. Essentially, we're going to, we have the arterial input function. I showed you how we showed you an example of that. And then we have the tissue function, which is the perfusion into the myocardium. If we can simply divide or deconvolve the tissue function, the arterial input function from the tissue function, we're left with our impulse response, which is our metric of myocardial blood flow. So how do we do that? Well, here's our regular pulse sequence. You have a saturation pulse, and then you have 3 slices of myocardial imaging that are acquired on that heartbeat, and then you repeat that at the next heartbeat, and you do that for the next 50 beats. Now, in order to quantify blood flow, we want to get rid of all the variability in your signal at its baseline. And so what we need is a very robust B1 and B0 correction. And here you can see that this has been numerically optimized in the new pulse sequence here. And then we need to accurately measure the arterial input function. I told you why we can't just use our regular perfusion images, and that's done using, what we do here is get a really low resolution spoil gradient echo. You can't use that for any diagnostic purpose, but you can quantify very accurately the signal that's coming through the LV cavity. And then we need to correct for any kind of variation related to the surface coil, and so you need these proton density weighted images in those same slice positions to correct it. And so the final pulse sequence will effectively look something like this. Now, here's an example of a case acquired using that sequence, and you can see on the left here we have resting perfusion, and here we have stress perfusion. You can, of course, appreciate this clear-cut perfusion defect here in the mid-anterior wall, but there's probably also a little bit of subtle perfusion defect here. These are what, now the next step is to segment your different, your endocardium and your epicardium and identify your arterial input function. And this is all done here in this example. And then once you have your time intensity curves and all your segmentation, we can now use the deconvolution process to calculate the blood flow in every single voxel in your image and create a color-encoded map as shown here. And you see during resting condition, the map is all green, which corresponds to about 1 mil per gram per minute, which is normal resting blood flow. And then at stress, you can see several areas increase into the gold range, which is 3 to 4 mils per gram per minute. And then some areas, like here in the anterior wall, where we wondered if there was a defect, and then clearly where we saw one here at the mid-level, remains green because the blood flow is not increasing as much there. And all of this can then be quantified and verified by looking at the curves, and then the segmental numbers can be generated to help you really carefully analyze and look at this data. Now, I've had the privilege of leading a multi-center study called the Assessment and Quantification of Myocardial Blood Flow. We call that the AQUA-MBF study. It's a collaboration between 10 centers that have sent us data sets and 5 additional core lab readers from 5 additional centers that were not actually acquiring data themselves. And what we found is that the blood flow measurements in healthy volunteers are on average around 3. And then those segments supplied that have late gadolinium enhancement or are supplied by severe coronary stenosis, you can see the blood flow is considerably lower. And so you can appreciate that this data was presented by Shua Wang at the American Heart Association this past year. And then here at SCMR, we kind of step back and present data. So what if we just get a global myocardial blood flow measurement, and how does that perform? And so here you can see in patients with and without coronary disease, resting blood flow is around 1 and normal. In patients with no obstructive coronary disease, you can see the stress myocardial blood flow is around 3, and in those with obstructive coronary disease, it's lower. And then the myocardial perfusion reserve is also different. Here you can see the ROC analysis to look at the diagnostic accuracy of stress myocardial blood flow. And first thing is we identify cutoff values at the moment here around 2.2 for stress MBF and MPR of around 2. And you can see the area under the curve here is in the 0.86 range, which is quite excellent for just a single global value. The other thing that's important for me here is that stress MBF alone performs as well as myocardial perfusion reserve. And why does that matter? Well, myocardial perfusion reserve requires you to get stress imaging and resting imaging. So here's an opportunity to get rid of your resting perfusion imaging, and that would shorten your scan time. And so I think these data and this quantification really helps sets the stage for that. Next is, here's another example. This is an 80-year-old woman with diabetes, hypertension, hyperlipidemia, and she comes in with angina. And for those of us who practice a lot of clinical cardiology, we know, I mean, this person has to have coronary disease. Well, look at her angiogram, it's beautiful. She doesn't have coronary disease. So what's wrong? Well, let's look at her stress MRI images. You can see resting perfusion on the left here is normal. Stress perfusion, maybe there's some subtle abnormalities there, hard to say. And then the quantification, if you look at just a stress MBF, you can see there's all these green areas where the blood flow is not increasing adequately. And when we quantify the numbers, we see that the stress myocardial blood flow numbers are all kind of borderline low, and the perfusion reserve is also low. And so what she actually has is coronary microvascular disease as the cause of her angina. And this is important because most of the myocardium is actually supplied by the microvasculature, not by the epicardial coronaries. You can just see the difference in surface area between capillaries and whatnot in the epicardial coronaries. We now are understanding that there are several patient groups that are at risk for having coronary microvascular disease, and very excitingly, there is now potential therapeutics that are on the horizon for this. So we can diagnose it and we can treat it. And it's important to treat it because there are, the presence of coronary microvascular disease impacts outcomes. And so no matter what degree of coronary artery disease you have, the presence of coronary microvascular disease is added risk. So another kind of, there we go. Another kind of exciting application is an opportunity for us to understand old diseases. So here's a patient. This patient clearly has cardiac amyloidosis. However, the resting perfusion, the stress perfusion all looks normal. When we quantify the blood flow, we can see that the stress myocardial blood flow is severely reduced throughout the ventricle there, and this patient has really diffuse coronary microvascular disease. It's not surprising if they got all this infiltrating amyloid all over there that the microvascular disease is also impacted, but we can quantify that now, and maybe that'll matter. Here's another example. This patient has clearly apical hypertrophic cardiomyopathy. They've got late gadolinium enhancement all at the apex. You get the stress perfusion on the right side there, and frankly, it looks normal. Again, when we quantify their stress MBF, you can see that their stress MBF values are severely reduced throughout the ventricle, and their myocardial perfusion reserve is globally abnormal as well. So here, in this patient with apical HCM, they also have severe diffuse coronary microvascular disease. And so, what that, how that correlates to patient symptoms and such, I think these are all things that we need to figure out how we would go about treating it, et cetera. So to summarize, deep learning can improve image quality on stress perfusion images. Deep learning can shorten scan time and improve image quality of late gadolinium enhancement imaging using free breathing PSIRs. Deep learning can help, it really helps us automate segmentation and allows us to collect the type of data we need to quantify myocardial blood flow. And quantification of myocardial blood flow not only allows us to accurately detect epicardial coronary disease, but also microvascular disease. And if we pursue stress-only imaging, it significantly shortens our scan time. I'd like to close by kind of combining the cine imaging and the single-shot LG imaging and these rapid perfusion imaging. As someone who, when we're at the scan, we're setting that 2-chamber view, the 4-chamber view, the 3-chamber. The time in between acquisitions takes as long or much longer than the actual acquisition itself. And so I see an opportunity to actually stop perfectly prescribing a 2-chamber. Just get stacks of 2 chambers that are, one of them will be right. Get stacks of 4-chamber, get stacks of 3 chambers, and get a short axis stack and move on. And then look at the images afterward. Help your technologists kind of get this stuff done more quickly, and they'll have to be less aggressively trained, let's say, to get the perfect 2-chamber, et cetera. With that, thank you very much.